All right. Good evening, everyone. Thanks for joining the Grand Rounds today. We're going to focus on a topic which is very crucial for research of the division. It's going to focus on a topic that recently received an R01, and I'm really proud that we were able to bring in together a group of investigators to lead investigations into how do we improve the risk stratification of acute myocardial infarction. As you would know, that the scores that we use, GRACE, Pursuit, STEMI, were all developed almost about 20, 25 years back. Ever since then, there's been a spectacular deal of advancement in medicine, particularly in imaging, electrocardiography, AI, and it's likely that some of these scores will be able to incorporate some of these new parameters. And to lead the investigation, it was very crucial that we have also an involvement from the clinical community that is able to bring into close connection of what these phenotypes mean and why they are important. So I'm going to start by telling a story, and this is a personal story. So a couple of months back, I had an episode of vasovagal syncope in the cath lab, and I was rushed to the ER, and there were multiple differential diagnoses. Of course, acute coronary syndrome is on the top of the differential diagnosis whenever you see someone who has got a syncope and potentially you want to rule out a cardiogenic cause of syncope. So while I was being investigated, I met someone, and that was the ER doc. So I'm going to now introduce our first speaker for today's presentation, Chirag Shah. Welcome, Chirag.
All right.
So Chirag and I met during this meeting, and it was very interesting that during this period also, I was able to quickly find out the person whom I should be collaborating with for my research. Because Chirag has been working in risk phenotyping and has been a clinician educator and very well regarded here in the institution. He's currently, just been told by him, and we would like to congratulate him. He has been promoted as full professor of emergency medicine at Rutgers School of Medicine. So Chirag started with his medical school at SUNY Downstate in Brooklyn, and following his residency at Brooklyn Hospital Center, where he was a chief resident, he started his emergency medicine career in 2006 at Rutgers Robert Wood Johnson Medical School, and he has been prolific ever since then. He rose through the rank of assistant associate professor and now full professor. He's the director of the emergency medicine residency cardiovascular block, and he takes great pride in lecturing both here locally as well as regionally, and now also very well known nationally on topics of electrocardiograms, STEMI, and what we're going to discuss today, occlusion myocardial infarction. He has numerous articles to his credit, over 100 published articles in many renowned journals and textbooks. And he's also a well-regarded reviewer in many of the emergency medicine journals. He's a board member and counsel of the New Jersey chapter of ACEP. He's an oral board examiner, has served in numerous oral board standing setting advisory panels, and he serves as the emergency medicine practice committee member for the National ACEP Task Force. He has been awarded Rutgers RWJ MS Emergency Medicine Residency Best Didactic Teaching Award. And today, what he's going to do is he's going to first present the talk by bringing into centerpiece why the topic of risk stratification is critical, and what is occlusion myocardial infarction, and are we up to speed? And following his presentation, I will come back and give a topic of how we are going to bring us up to speed by renewing our risk stratification strategies using some of the newer developments. With that, Chirag, the floor is yours.
Thank you very much, Partho. I'd like to thank the Department of Cardiology and you, Partho, for inviting me to speak to you all. I'm just going to share my slide. All right. So, upon us, we have the occlusion reperfusion era. And as you all know, my name is Chirag Shah. So, disclosures, I have none. So we have two main objectives, I think, more so differentiating this occlusive MI that we talk about from STEMIs that we're sort of used to seeing, while emphasizing the limitations of the traditional STEMI criteria that we all know. Also recognizing high-risk ECG patterns suggesting OMI, and to really improve the early diagnosis and timely reperfusion therapy, and whereby we really try to reduce morbidity and mortality. So their question then was, is the patient having a STEMI? And I think now with this occlusion paradigm that's upon us, it's really more the question is, does the patient have an acute coronary occlusion that would really benefit more from immediate intervention before that STEMI that we're thinking of sometimes? So, initially we had this classification of Q-wave versus non-Q-wave MIs. We then moved to the reperfusion era where, we started looking for STEMIs and non-STEMIs. And then now with the occlusion reperfusion era, we're really looking to see if there's an occlusive MI or non-occlusive MI. So reperfusion era, what happened? Well, it showed that reperfusion worked. If you had a pipe that was blocked, you open it, you can restore some flow. It was great. But it didn't quite completely answer who should receive that emergent reperfusion therapy. So when it was looked at, about 25 to 30% of those patients that were classified as non-STEMIs actually had an acute coronary occlusion. So that's almost a third of the patients that we see that we could have potentially acted upon earlier and maybe made a difference. So this is a sort of a busy slide, but I think it really, really hits home a lot of this. There was a fibrinolytic trial meta-analysis. This was back in Lancet, way back in 1994, but they really broke down, what happens. And, this was a graphic from Dr. Smith, who's one of the big proponents of this in the EM world, emergency medicine world. And they talked about lytics versus cath without an EKG subgroup. And the number needed to treat was just 56. When you start pulling in that reperfusion error and start talking about STEMI criteria, the number needed to treat was 42. But when you broke it down and went into the occlusion perfusion era, when you had a true acute coronary occlusion, the number needed to treat actually decreased. The number needed to treat was less than 42. When you looked at ST depressions, which were really not considered so much of something to intervene, the number needed to harm was 42. But when you break these ST depressions down, such as a posterior acute coronary occlusion, those number needed to treat again was less than 42. Same with thrombolytic thrombotic left main disease, also less than 42. And when we have these quote unquote normal EKGs, there were things there that we can look for, such as true positives like hyperacute T waves or, these sub-millimeter ST elevations, and those number needed to treat was less than 42, meaning we really should look at this area of group of patients that we should really intervene on earlier. So, and there were always some false positives as benign early repol or LVH or left ventricular aneurysms and pericarditis, where the number needed to harm was greater than 0. So this is actually a pretty good graphic. When you look at all-cause one-year mortality and you look at STEMI, it was 9%. When you look at non-STEMI one-year mortality, you're approaching 18%, double. And when you actually start looking at the hazard ratio, you have a hazard ratio of 1.84, really meaning that the one-year non-STEMI mortality is 84% more likely to occur in the treatment group compared to the STEMI group. This is really concerning, meaning we should really look at this population as something to intervene on. There is also a 5-year, which Dr. Smith has in a manuscript that's in process. But when you look at the STEMI in a 5-year, it stayed fairly consistent at 9%. But when you look at the non-STEMIs or these OMIs, you're going up to 27%. And when you look at their hazard ratio, it's 2.59, which means it's 2.59 times more frequently compared to the STEMI group. And when we look at our time to coronary angiography, you have someone with a STEMI, it's fairly easy, right? You call, they go in, your median time was 1.4 hours. Great. Now, what about when you talk about these non-STEMIs, OMIs, you're hitting 16 hours. And then when you have these non-occlusive MIs, non-STEMIs, you're hitting almost close to 2 days, 45 hours. So there's a lot of gap and time where you could have intervened early and actually benefited the patient. So, in November 2022, we have the ACC that had their consensus and pathway on how to evaluate patients with acute chest pain in the emergency department. And then just recently, there was an article just published about a month or so ago, roughly, which talked about EKG patterns of occlusion MIs, a narrative review by Dr. Smith. It's actually an excellent read. So this was just in April. And some of the patterns that I just want to bring up, we're used to seeing Wellens A, Wellens B, some hyperacute T waves and sort of following that sometimes and using our point of care to rule out hyperkalemia sometimes when that's a concern. De Winters, the one that I really, was sort of surprised by is Aslanger's pattern, which we'll go over really quickly in a few slides, as well as the South African flag sign, which is a little bit more easier to see with the elevations in 1 and AVL and V2 as well. And then the ones that are coming up more so now that are sort of different are the new onset bifascicular blocks, which is very interesting. Posterior MIs that we're all sort of accustomed to seeing and sort of intervening on. Terminal QRSs. The modified Scarboza Smiths, which was actually based on this Dr. Smith, who actually has the modification, which is now part of the ACC guideline. And then there's something called a precordial swirl, just looking at V1, V2, and then seeing the change into V5, V6. And then the northern MI, which is another type of finding. So how do you really tell who has an occlusion MI, right? I mean, you have to look at the examples. You have to look at what kind of discomfort they're having, what kind of story. This is a patient comes in with chest pain. You sort of look at this. It's not overwhelming, anything acute, maybe some STs, but depressions maybe in the anterior lateral leads. But when you look closer, you look at lead 3 and you see that little elevation there, just subtle, not massive. And then you sort of look at, you see this concordant ST elevation in lead 3. You look at lead V1 and you see that elevation there as well. And that STS segment elevation is higher than in V1 than in V2. And then you also look at V4, V5, V6, and you look at all these ST depressions here, and there's something concerning. There's some sort of pattern. And this is a patient whose initial troponin was 12,000, went up to 29, and their cath actually had 100% RCA, 85% LAD, 80% ramus. So that is a patient that we really don't want to miss. And this is named after the person who's actually found it, who actually works with Dr. Smith. His name is Dr. Aslanger, so it's considered called the Aslanger pattern. And, it's really seen in 6% of non-STEMI patients. That's quite a few, and the specific pattern, like I mentioned, was any ST elevation in lead 3, but no other inferior leads. ST depressions in V4 to V6, and then an ST elevation or segment that's higher in V1 compared to V2. So when these patients are found, when this sort of pattern is found, it's sort of predicts an inferior OMI with concomitant critical stenosis in other coronary arteries. It is not only the RCA, but it's more of a multi-vessel finding. So it's really the absence of ST segment elevations in the contiguous leads, because we're always so used to looking for contiguous leads and elevations in contiguous 2 or more contiguous leads. It's actually, when you have this pattern, there are things that will help predict if the patient's going to have a large infarct size, such as if their 24-hour troponins are higher, if they have a higher frequency of angiographic culprit lesions, and also endpoints in terms of what their composite acute coronary occlusion endpoints are. Now, when you look at this, these patients exhibited a similar inpatient 1-year mortality rate as those patients that had an inferior STEMI, which means we really need to address these patients earlier and sooner. This is a, EKG, and I'm sort of, these are EKGs that we get in the ER. And, when we look at this, it's concerning. You see this, yeah, it looks more right bundle, it's fine. But then when you look at V2, V3, there's this concordant type of change. And so what can we really interpret this? And yes, there is, you can, I've heard different, thoughts, but, initial criteria was a scarbosis that we all know based on a tier system in terms of points. And if you score 3 points or more, it's considered an acute MI. But the problem was the specificity is great at 96%, but the sensitivity was horrible. It was 36%. So what does that really mean? It's great when it's positive, but when it's negative, it really doesn't rule out an MI. So it's not really as helpful as we thought it would be, although it's better than nothing. But then Dr. Smith modified this and said, let's change it to concordant 1 millimeter ST elevation in any lead. Then you have a concordant depression in V1 to V4, V1 to V6. So when you have these kind of findings, you want to look. And then the more that I really like, and that I also use, is actually just looking at the ST to S ratio and seeing if it's greater than 25% in any lead. And the specificity was a little lower at 90, but the sensitivity went up to 91%. So when we have these kind of patients, we really should be able to apply these rules and apply it to patients who have a bundle branch and a pace rhythm. And this was accepted by the ACC in 2022 in the consensus pathway. So this is a rule, this is a criteria that is now taken over the regular scarbosa to be applied. So this is what we talked about, the 1 millimeter ST concordance. This is the discordance, but this is the ST to S ratio. And this is, I think, one of the easiest things to look at. You just see how tall the ST is, take the S wave and see how deep that is, and just actually simply get a ratio, get a percentage. And that is all. If it's greater than 25%, then you know you're dealing with an MI. And this is another paper that actually showed that this criteria was effective and was good to be applied in patients with paced rhythms. They had a sensitivity of 81% versus the original, which was only 56%. So is it 100%? No, it is not. But is it better than what we had before? Yeah, by quite a bit. This is another patient that I had, and I had a conversation with one of the interventionalists about taking the patient up. He was a 42-year-old gentleman who had chest discomfort, burning in his chest, a little shortness of breath, did not look good. And when you look at this, these ST depressions diffusely really worry you, but the forgotten lead of AVR, this elevation, really concerned me too. And we had a great discussion, and the patient was taken to the to the cath lab. So when you have these ST elevations that are greater than 1 millimeter in AVR with all these diffuse ST depressions, it can mean left main, but it can be other things as well, triple vessel, proximal LAD. But especially if these patients have these accompanied by pathological Q waves or hemodynamic compromise. And this is exactly where Partho is talking about employing the ultrasounds and so forth into our practice that we've been doing more so recently. And the ST depressions are most prominent in the inferior leads and the lateral leads, and really thought to represent subendocardial ischemia. So it's not, although, someone can look at this and say, oh, I think it's only an occlusion MI, but it's not. It can be present in other situations like a pulmonary embolism, aortic dissection, LVH with strain, or even stress on the heart from hypoxia or an acute anemia. So it is something that you have to, that I have to make sure when I'm calling you that I sort of have already thought about these differentials as well. But very interestingly, that back in 2013, the American Cardiology Foundation, as well as at the AHA, the guidelines were if a patient had this type of EKG pattern with presentation concerning for an ACS, they should have invasive angiography. So the likely issue on these are more so the left main, but it can be the proximal LAD and it can be triple vessel disease. This is the one that I bring up because it's quite interesting, because when I sort of learned about MIs, the big thought was, or teaching was, if you had a new onset left bundle branch, then they had a high risk of an MI and they had a proximal LAD. And, the traditional thought is actually being challenged nowadays. And the reason is they're looking at a necroscopy study, and they're looking at based on the blood supply. So the LAD is actually supplying the right bundle and the left anterior fascicle. And that's in about 90% of the cases. Whereas the RCA is supplying the left posterior fascicular fascicle in 90% of the cases. So when we look at this, a dual blood supply to these fascicles occurs in about 40 to 50% of the times. So therefore, when you obstruct a left proximal LAD, you can actually get a right bundle or a left anterior fascicular block. But for an myocardial infarction to cause a left bundle branch block, you would have to, in theory, have an occlusion of the proximal LAD and RCA. And the likelihood of that is really just, I don't think anyone's ever going to see it, and likely will ever see it, right? So it is the whole twist of teaching where it was initially the left bundle branch or the new left bundle, where now I think we need to look at a right bundle that's new and potentially with the fascicular block that's new. So I think this is sort of coming through, coming up more so, down the pipeline, I think, more so. So acute MIs can present with right bundle branch block. It's just usually from an acute coronary occlusion, and they frequently managed with primary PCA intervention than really those presenting with a left bundle branch. And in 2023, the European Society of Cardiology recommended reperfusion for patients who are exhibiting signs and symptoms of ongoing myocardial ischemia with a right bundle. So, when we talk about this, what do we do when we have this? Well, when you get an EKG, you want to see are STEMI criteria fulfilled? If they are, then you really want to also exclude other things. Are there any secondary causes of these elevations that you're seeing? Is it artifact? What are the primary causes of the elevation? And if they're present, if the STEMI is, if any of these artifacts or secondary causes are present, then those are more so mimics. Versus if they're not present, then that's truly a STEMI occlusion MI. When we talk about STEMI criteria fulfilled or not, if you don't see a clear STEMI, then you really have to look through and really look at all these other things, such as a subtle ST elevation, Wellens, hyperacute T waves, De Winters, Aslanger's pattern, the South African flag pattern, the new onset bifascicular block, posterior MIs, terminal QRSs. You really need, if there's a bundle branch or a pace rhythm, really try to use the modified Smith-Scarboza criteria. There's also something called a precordial swirl and northern OMI that I won't sort of get into here. But you want to see if any of these are present. If any of these are present, then it's a non-STEMI, but they're an occlusion MI. Versus if they're not present, then these are non-occlusion MI, and you can continue your workup on the patients. So hopefully I've fulfilled the objectives that I sort of promised initially, was to try to help differentiate OMIs from STEMI based on EKG findings, as well as the limitation of a traditional STEMI criteria definition. And then also looking at some of these patterns to make sure that we sort of intervene sooner and try to reduce the morbidity and mortality for the patient and do right for the patient. So there's a bunch of more so credit to Dr. Smith, who I communicate with, as well as some references that I have that were possibly not on the slides. And thank you for your time. Any questions?
Thank you, Chirag. So I think what we will do is we will come to the questions.
Okay.
I'll make a presentation now, and then we'll come back. Thank you very much for setting us up. I'm going to go ahead and share my slides now. Let's try and see if we can get this going. I'm going to change my display. All right, so the question that comes up, are we up to speed? And as Chirag presented, it's complicated, right? So you have so many new EKG patterns that you would need to know. And when he's talking about occlusion MI, what does it mean? Well, the term occlusion MI is reserved. It's an angiographic definition, right? So it's not an upfront definition. You're trying to recognize occlusion MI, which is an angiographic phenotype, And it's typically been defined as if you have a culprit lesion with a TIMI 0 or 1 flow, or even if angiographically you feel like the stenosis is 70% or more, and there is a TIMI 2 flow. These are two definitions that have been taken. Of course, this is associated with the classic type 1 presentation, chest pain, troponin elevation, and features that suggest the patient is having acute myocardial infarction. But the phenotype that we are trying to look into is presence of an occlusive lesion that is flow limiting. And our traditional EKG ST segment, as we all now know, is got a sensitivity only of 30 to 40%. So it may not predict. So ST elevation is only a small proportion of patient. And as correctly pointed out, 30 to 40% of patients who are STEMI equivalent and have complex electrocardiographic presentations will not be taken to the cath lab. And maybe that's the reason, because of the complex presentations of non-STEMIs in randomized control trial, when these patients have been taken for primary PCI, the protocols have not worked out because we have not been able to isolate the subsets of the phenotype that would benefit more. And you just took everyone in with non-STEMI and it doesn't work out. So are we up to speed, and what do we need to do? And this became an investigation where we felt like AI would be very useful. Think about the clinical presentation, the electrocardiogram, maybe the point of care ultrasound. If you would be able to feed it in an AI algorithm at the point of care, and you would be able to get, instead of this cognitive overload of someone not being able to diagnose the condition, you have a flag that this could be an occlusion MI, and then you actually are able to get a higher level of care that would be useful. So with that, these are the disclosures we started off with, and we were very excited that we were granted the R01, which is typically over a 4 or 5 years period of time, you're investigating a special area of interest. And this one, in this case, we were looking into how do we better stratify patients with MI, and how could we use AI techniques. And to give the story of ultrasound images, I would like to take you back almost about 10 years back, when the whole journey began. And the whole journey began, actually, believe it or not, at a butcher shop. So this is a butcher shop in Rochester, Minnesota. When I was visiting there as a research fellow, and many of you may or may not be knowing the story, I was sitting there and waiting for my IRBs and protocols to come in. And then I got waiting, I got a little frustrated, and I said, okay, let me do some animal protocols. And when I started planning the animal protocols, I found that you also need approval for iCook protocol that will take about a month more. And I was spending about a year's time in my research fellowship, and 3 months had gone and nothing was coming out. So I say that I'm going to do something which will be different. Nobody can stop me from dissecting human hearts that are coming from a butcher shop. So I went to this butcher shop and I ordered for all kinds of hearts. And those all hearts came wrapped up in a pizza box. And every day I would thaw them out from a deep freezer in a break room. And I did dissections, and I started playing around with ultrasound, scanning them, and so on and so forth. And that led to a realization that actually the muscle organization in the heart has got a very strong reflection pattern that emerges from an arrangement, which is very, very, very classically recognized in imaging. And these experimental data that came from the butcher shop, believe it or not, went finally 3 years later into the guidelines. And this is the work on, we were looking into how when the ultrasound beam comes and strikes the different planes of fibers, the planes which are orthogonal or at right angles to the beam of the ultrasound will have the strongest reflection. So now if you ever go back and see an ultrasound image, and if you see bright stripes anywhere, immediately you should know that those are the places where structures are at right angle to the ultrasound beam. Be it at the midstripe, this midstripe in the septum, this is actually the place where the fiber orientation is changing from one helix to the other, and it becomes almost at a right angle. Or be it this line, this is at a right angle. And this is not just seen in ultrasound. Actually, this arrangement has a big impact on all kinds of imaging. So this is actually imaging of MRI of a animal heart, a pig heart. And you will see this, if you just connect these two reflective layers, which are moving in two different directions, and you will see this helical pattern. So these are the fiber arrangement in our images. So the pixels or the speckles or the patterns that you see in our images actually have a deep construct on the arrangement. And this arrangement is disrupted in disease states. So if there is a way for you to analyze these pixels or the speckles, you should be able to identify abnormal and normal patterns. And what we did subsequently was to show you, this is a heart in a MRI plane, and as the plane passes from the apex of the heart towards the base, you will see the swirling architectures in two directions. You see this is the ultrasound image. You see the swirl going in one way and the swirl going in the other way. And if you see the MRI image, you'll see the swirling pattern in two opposite directions. These are helical structures of the fibers. So both ultrasound and MRI, the images, actually the speckles or the pixels, are heavily dependent upon the underlying architecture, which gets disrupted in disease state. And do these impact the images in a beating heart? The answer is yes. So I went into the OR subsequently, and I took an image. This is an ultrasound transducer on a beating heart, on a naked beating heart, just put on the surface of the heart when they were doing a CABG surgery. And what you see is the speckles or the pixels are moving in two opposite direction, because the inside layer is moving in one direction, the outside layer is moving in another direction. These are pixels or speckles, which means that the underlying constructs of the two different orientation of muscle fibers are creating different types of pixel patterns. So we exploited that, and we decided to use the pixels from the images of the ultrasound. And we had our first publication in Lancet eBiomedicine that you would be able to construct from this myocardial pixel set images, and you could actually connect even a 2D ultrasound image to give you information that would come from an MRI. For example, MRI is the gold standard currently for infarct quantification. Late gadolinium enhancement is what we use for infarct size. In ultrasound images, you cannot see the infarcted region directly, but you can study these pixelated patterns and be able to extract the region that is getting infarcted. So this was our first work in Lancet eBiomedicine, for which Nobuyuki Kagiyama won the Young Investigator Award. And then subsequently, we filed a patent, and believe it or not, this was my journey to introduction with Dr. Yanmala, who was introduced to me as a special consultant on this patent. And ever since then, of course, the journey kept getting better and better. We exploited further the pixel and the speckles of the ultrasound images, and we showed in a reverse translational method that it is possible to actually develop information that is coming from myocardial, from the myocytes, at the myocyte level, from the histological level, and understand different types of hypertrophies, which are actually at the level of the myocyte. to the organ level, both connected. And Quincy Hathaway won actually the William Parmalee award for the best paper in JACC for this particular work. Taking this one step further towards myocardial infarction, we have recently developed the preliminary data that was presented for the R01, which became the reason we got the award, was to show that it's possible to extract the information from even point-of-care ultrasound images. You extract the images, take the images, you distill out the pixels, and when you distill out the pixels, you're able to get AI algorithms that can read the patterns and tell you what is an infarcted myocardium and what is a normal myocardium. And not only it is able to give you information about presence or absence of infarcting muscle at a given time, but also it is able to colorize it, just like you see in MRI. This is a patient with an infarcted myocardium. You can see the dense late gadolinium infarct pattern in the interior wall and over the apex. This is the same patient where now you have on the ultrasound image, you can see the bright spots are the infarcted myocardium, or this is the infarcted myocardium, and you can see the same area which is infarcted versus a normal myocardium, which would look different. And we were able to see that this particular delineation works better than conventional wall motion analysis and even longitudinal strain. And that became a reason for us to start focusing. Can we identify patients at large risks of MI or larger infarct area at risk using these approaches? And the work that we are now currently going to do in the next 4 years is going to focus into 3 areas. The AIM one, which has already started, is going to do develop an AI algorithm that is going to be developing a risk stratification score, which is better than what we use currently, like GRACE or STEMI. And in this, we're going to take the electrocardiogram, the images, the clinical data, the tabular data that comes from the patients, and we're going to train towards a prognostication risk score that will detect the risk of death at 1 year. And this will be a retrospective work, which has already started, which will be in the phase year 1 and year 2, and in which we will have multiple sites within the Rutgers-Barnabas health system and AMI patients and databases. And we will be looking into developing this risk stratification, prognostic risk stratification score. There is a large sets of investigators involved, and here are some of them identified. So we have a center group of people who are spearheading the steering committee. Bernard Chapman, who is the chair of the myocardial infarction task force, along with Dr. Carson, along with multiple investigators from here, Dr. Bukhari, Isad Busik from NBI, Jordan Strom from Boston, Kuram Nasir from Houston, and also engineers from here, Dr. Yan Mala, Dr. Don Ajora from West Virginia University, Gianfranco Derrito from West Virginia University, along with host of postdoc fellows, Ankush Jamtikar, Kevin Lippert from NBI, Shrikanta Nepali, who's working at Somerset. They are going to be the adjudicators for these patients, and they are supported by research assistant. And we have identified multiple residents in the first and the second year who are working on different aspects of myocardial infarction. A group is looking at the clinical phenotyping, a group is looking at hematological and biochemical phenotyping, and the third group is looking at EKG and imaging phenotyping. All of this are going to be added together to get a multimodal way to look into the stratification risk score. The second year is onwards, we are introducing the effort to identifying patients with occlusion MI. This will be a prospective study, and this is going to start next month. And this is where I would like to invite each and every one of you, because this will be a prospective study. Patients who are coming into the emergency room or who are identified as type 1 MI, those who are so labeled as non-STEMI, whom we think there is a likelihood of a high risk. So basically, anybody with a heart score of more than four or more, whom we think is a high risk, we will include them. Particularly, specifically people who are in whom we are going to take them for coronary angiogram or CT coronary angiogram, because we want to have also the phenotypic data sets. And these people will undergo point of care ultrasound. We will use the AI techniques. Not only we will use the conventional assessments, but we will also subject it to AI and develop new models for risk stratification, finding out subset of people who are going to be having OMI and need to be taken early for revascularization. This will go for the next 2 or 3 years. The target is to enroll 200 patients. And what we want to do is we want to make sure not only we enroll them with the hypothesis that it's possible for us to use AI tool to reduce the cognitive load for detecting patients who are at risk of developing OMIs or call as OMI and taking them early for intervention, but also making sure that we correctly phenotype them. There are certain exclusion criteria, particularly we are not taking the other type 2 and to 4 and 5 MIs, coexisting cancers. They have previous cabbages, poor imaging quality. If they have STEMI and non-STEMI caused by some secondary cause like motor vehicle accident, trauma, and some other host of other contraindication for doing an invasive route, we will not take them. For those reasons, therefore, while we are selectively enrolling them, we will open up a registry where each and every patient, even these people, will be able to come in, and we will be able to observe them over a period of time of how do they behave. Because ultimately, while we are interested to develop this AI algorithm to prove us towards OMI, we also want to make sure that we need to see the generalizability in all the other patients as well that are going to be excluded. So they will be included into a trial registry, which will be actually clinically available for further data mining. And we will target towards doing the point of care ultrasound, the conventional ECG, using AI approaches, and looking at the targets of diagnosing severe obstructive coronary artery disease, including OMI, and also some other high-risk phenotypes, particularly 3-vessel disease or 2-vessel disease involving proximal left antrodescending artery. There is an AIM-3 in which we are aspiring to try to see if the images from the ultrasound could start giving the same information as an MRI. So there will be a subset of patients from this will undergo MRI, and will have head-to-head comparison of the pixelated pattern that comes from the AI in the ultrasound images, and we will compare that to those that comes from MRI. What I'm trying to present here is this huge opportunity to make a huge difference. The reason being, it is gaining more and more recognition that the current paradigms of STEMI, non-STEMI is bound to change. The current paradigm also of how we call coronary artery disease, the nomenclature is consistently changing. As you will now know that we have recognized that there are a large number of patients who present with acute coronary syndrome would not have complete plaque disruption. We know that the fibrous cap stays intact, and they just have the endothelial denudation, and a thrombus develops on top of it. So there is no plaque disruption. And these subsets of patients are called as plaque erosions. And these plaque erosions lead to what is known in the literature as non-occlusive MI. So a lot of the patients who don't have occlusive coronary angiogram actually have plaque erosions with a thrombus. So the whole field of coronary artery disease, the phenotypic presentation, the variations that we see in gender, the variations that we see in non-STEMI presentation, compounded by also our inability to really phenotype macrovascular disease. This is really a paradigm shift. But to top it all, it is important that the common presentation with which we are taking patients to our cath lab, particularly STEMI and non-STEMI, is likely to change in the very near future. There is a strong force that I'm seeing. If you see the current JAK advances, the occlusion, non-occlusion MI is starting to take a centerpiece. So it is a very nice time for us to group together and join hands in this very common disease that you're playing an important role every day, and make a change in how we diagnose. It does not require to be AI. It's a conceptual change of how we recognize these diseases, the pathologies, and how do we take care of them. And that's the plan, and that's how we're trying to bring it, a group of investigators from across the health system and beyond together. And it's a call which is open-ended. If you have an interest to be part of this team, please reach out to me. We'll try to make sure that we can group you all into different investigative teams. And I think we are really looking forward to taking this journey over the next 2 or 3 years. Thank you very much. And I think we will have 10 minutes or so for a Q&A session. Please unmic yourself and feel free to ask a question to me or Chirag. And Chirag, particularly for your amazing display of those complex ECG phenotypes, which many of us actually do or do not do well at. And I think this is something very important because it impacts patient care. And your slide that shows the non-STEMI outcomes are poorer over time. And they also have a lot of comorbidities. We also know they come in with a lot of different comorbidities. And if you look into the STEMI and the non-STEMI paradigm in the community, the non-STEMI prevalence is increasing. And so I think we are seeing a phenotypic shift and of how patients are presenting to us. So I think there's a very important need for us to organize ourselves in this evolution and trying to understand the disease. Thank you very much. Open to questions.
Arthur, I have a comment and a question. Two excellent presentations. One comment that I think we still have to be careful when we apply, especially if you apply AI to these models, you have to make sure that the ECG has the appropriate, doesn't have any of the exclusion criteria. For instance, in the Aslanger pattern, the EKG was paced, so I don't think you can apply that to that EKG. And the Scarboza doesn't apply to right bundle branch block or the Scarboza-Smith. So I still think there's an important identification initially, rather than looking at the, you sort of miss the forest for the trees if you just look at, different ST patterns and so on. And the question for you was, what's the time course of developing this pattern on the ECGs that identify, on the echo that identified the MI? Does it occur after 2 hours, after 6 hours, after 30 minutes?
So, Jim, thanks for important questions. So I think we are taking a very open-ended approach. Look, I mean, I think there are some EKGs which are capable of diagnosing OMIs, and there's particularly one EKG paper in Nature Medicine. If you look, I think 1 or 2 years back, which was published from University of Pittsburgh, it did pretty well actually. It's in a large database. It has been able to show a good diagnostic AUC was in excess of, I think, 88 or 90%. And subsequently, there are some EKG models that are currently approved by FDA that are available. I came to know about some of this being applied. So you're right about these AI models when they read out to you. What does it mean? I would think they should be used as a flag rather than as I maintain that AI cannot take away the human intelligence, right? You augment yourself. So basically, uh, uh, instead of those EKGs being missed out, if there is a flag that there's a special attention needs to be paid, particularly in the emergency room, or at least in ambulances, where maybe a lot of people do not know how to recognize some of those very difficult signatures on the ECGs. So I think I'm looking forward to probably using it for augmenting our team's ability to recognize subsets of patient. I think they will come with their own sorts of misgivings, in the sense like there will be false positives and so on and so forth. But I think this is an iterative process. So coming back to how they will be developed, at the moment, I don't think we are going to change the clinical standard of care. So the data will be, the AI models have been developed in retrospective data sets, right? So they will be implemented in a prospective fashion in standard of care. So some of the echo models are already currently available from FDA. For example, there is echo model that we can use for looking at wall motion analysis that automatically tells you the presence or absence of wall motion abnormalities. These are FDA approved. These algorithms can be used. When we are talking about some of these complex models about looking at the infarct, that's a little bit more exploratory. But the data for this will be collected and used prospectively. This is not a study where we are looking at the effect of implementation, or it's not an RCT where we are looking, if you apply this tool, does it do better than the standard of care? We are not doing it. We're looking in the standard of care of what is the AI capable of doing in a prospective fashion. And once we succeed there, of course, then the randomized control trial need to come very quickly. I hope I have answered your question. If I have not, let me know which aspect need further clarification.
I just had a question about the time course of the pixelated pattern. And does that indicate that there's a change in fiber orientations?
So a good point, Jim. So right now we're taking two sets of images. So one will be the point of care ultrasound right at the time in the emergency room, wherever the team meets for the first time, wherever the first point of contact. And then we will do it just before the discharge along with the MRI. So yeah, you could probably talk about multiple images to be taken, but it will be cumbersome. So we took at the presentation and then when the infarct is developed, because typically 5 to 7 days is where the MRI is best in characterizing the infarct. And that's the time point. The second time point is when we will have the second sets of ultrasound for seeing the actual infarct, presence of infarct. Now, before that, actually, infarct evolves and already there will be hypokinesis, but it cannot actually tell you about dead myocardium. I do not know. The MRI is able to tell you, but at that time there's a lot of edema and other viable myocardium also have the same pattern. So it becomes a little bit more clearer pattern after 5 to 7 days. That's where the infarct size is developed and better seen on MRI.
Thank you.
Yeah. Any other questions?
So, Dr. Sengupta, I had a question for Dr. Shah. So, I mean, when you talked about the ST, especially the OMI with multivessel disease, do you see disparities in care or how should I say, the changes depending upon different types of cohort that show up in ED, Dr. Shah?
Not so much the cohorts. I think it's more the ones that I've seen it more so in are more the younger patients. But in terms of getting the care, it doesn't meet that typical standard that we're used to of going to cath. So I think that's where the disparity happens. But I think a lot of that is the conversation with the interventionalist.
Mm-hmm. Thank you.
But I can tell you, Navina, I think our clinicians are pretty astute, and they're able to recognize patients quickly who needs to go to the cath lab. But there is a pragmatic way of how non-STEMIs are brought to the cath lab, right? So if there is no availability, or somehow you cannot, like, it doesn't work like STEMI, right? So even if there is an emergence, it waits for hours. They're not opened up the same way. What we're saying that they need to be probably opened up if the artery is occluded. They need to be treated like STEMI. I don't think that happens to anybody, any of those occlusion MI. Very rarely. I don't know if anybody gets it, if it is recognized well in time. Only I think probably someone has got a cardiogenic shock as a result of that RV infarction or something else. But majority of the patients don't, all across the country, don't get it in time.
And from a hospital standpoint, Dr. Sengupta, the NSTEMIs, weekends, they typically don't go to the cath lab.
Correct.
The weekend availability is almost like non-existent. All subsets of NSTEMIs are treated uniformly. We don't differentiate. So this was huge and hugely eye-opening. Thank you.
Yes. So many of those patients that are sitting over the weekend, because they're non-STEMIs and may actually have underlying occlusions, and they're completely infarcting out.
Yeah,
I'm
especially the
almost-
timeline. Yeah.
Sorry, just one quick thing. I'm almost wondering, and I don't know, I mean, this has kind of been amazing, so I'm going to have to go back and read up a little bit on it. But I'm almost wondering if there's an influence of this, the occlusive versus the non-occlusive subsets of NSTEMI, if that later influences myocardial remodeling. Sort of the patients with ischemic cardiomyopathy that tend to recover after 4 to 6 weeks and no longer need, for example, an AICD or something like that, right? Because the EF recovers. I'm almost wondering if there is something like an influence in terms of the pathology.
Yes, Kiran, so you'll be very surprised. There is data on occlusion MI. Those people who develop larger infarcts, and they develop large infarcts, they will lose their LV function. So I mean, okay, so the infarct size is the direct correlate of LV ejection fraction and recovery. LV will not recover if the infarct size is large. It's a transpleural infarct, and people with occlusive MI will have transpleural infarct. Their LV function will not recover. They will behave the same way as STEMI would behave. So that's what the eye opener is. And their MACE and adverse events are higher. There's already data on that.
Yeah, their 1 year mortality and their 5-year mortality really it's huge. 18 and then up to 27% in the 5-year.
So yeah, it's an eye opener. I mean, it's like you almost wonder. I mean, I think a lot of people across the country are scratching their heads on this, right? The problem is there is no way for us to bring these people quickly into the cath lab because there is no paradigm. And that's the place where we need to see how we recognize them and find them into our cath labs quicker.
Yeah. Thank you.
And thank you for joining. I think you're going to play an important role in some of these protocols that you're going to implement, Kiran.
Thank you.
All right. Mike Cargill is there from cath lab. Mike, what do you think? Can you bring in some of this OMIs to the cath lab? Have you had any such findings ever with non-STEMIs getting delayed and then they had very high-risk lesions?
Yes, I could say that we have brought quite a few, high-risk non-STEMIs to the cath lab. And yeah, like you've been saying, the challenge is like when you have a non-STEMI, people tend to wait. People tend to do scheduled cases ahead of it. But as Dr. Shah's said, like we need to open it up to a bigger population that may not have that may have disease, but needs to come to the cath lab sooner than later.
Thank you very much. And I also recognize that there are some important investigators who have joined from outside. I see Dr. Gianfranco Doretto, who is our AI leader, from West Virginia University. Thank you for joining, Gianfranco, and Dr. Yanmala and Gianfranco, and they're all working together on the AI algorithms. So looking forward to this evolution. With that, I think thank you all for joining. We are really looking forward to presenting to you some important findings from these studies that we are going to do over the next 1 or 2 years. So stay tuned. And if you're interested to work with us in this large, sets of data sets that we're collecting, thousands of patients, please feel free, because we are very interested to engage every one of you, because all inputs are welcome. All collaborations are important. Thank you all.
Thank you.